Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center in Des Moines and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is Cancer in Iowa 2024, which is a report from the Iowa Cancer Registry. And we are so honored to have with us Dr. Mary Charlton, who is the director of the Iowa Cancer Registry and associate professor at the University of Iowa. Welcome, Mary.
Thank you, Dr. Deming. It's so nice to see you again.
So Dr. Charlton and I are colleagues, and we also serve as officers in the Iowa Cancer Consortium, sort of our Iowa Cancer Control Organization. So it's been a real pleasure working with you and getting to know you. And so before we talk about the Cancer in Iowa report, let's learn a little bit about you. Where did you grow up, Mary?
I grew up in Omaha, Nebraska, just across the river.
All right. And where'd you go to high school?
Burke Bulldogs.
And is that a big? How many in your high school?
It's pretty big. I think maybe there's about 1,800 people at my high school.
Okay.
And the colors were black and gold. And the colors of my grade school were black and gold. And I went to the University of Iowa 3 times where we were black and gold. So I've only ever been black and gold.
You didn't. You had one wardrobe that worked the whole way through.
That's
what
right.
was your claim to fame in high school?
Oh boy, in high school, I played soccer, but I don't even know if I don't think I was famous for anything in high school. Okay. In junior high, I was the first, maybe in 5th grade, I was the first person to be able to shoot a 3-pointer in basketball. Oh. So my nickname was Mary Bird. So that might have been the only claim to fame I ever had.
Nice. And if you just had stuck with it, you could have been a Caitlin Clark.
I know. I do love Caitlin Clark, so I love watching her. So it's been fun.
So when did it become your dream to become an epidemiologist?
Well, it took me a while to figure out what that word meant. I remember my mom, when I told her I was getting my master's in epidemiology, she put a little sticky note by the phone with the definition I gave her so that she could explain to people what that meant.
Yeah.
So I'm not sure I knew exactly what it meant until I was in Chuck Lynch's epidemiology, Principles of Epidemiology 1, where it truly sunk in what it was. But I just
undergrad at the University of Iowa.
That was my master's.
That was your master's.
I sort of took a leap of faith that because my undergraduate degree was in nursing. I really liked research, and I knew I wanted to get into research. And that's when they started the College of Public Health right then. And I learned about a program called epidemiology where you could do all this clinical research and different types of research. And they said my nursing background would be good for that. So I kind of took a leap of faith that I would like it without 100% knowing what it meant until I started the program.
But you got your nursing degree.
Mm-hmm.
And then you worked as a nurse?
I did. Yep. I graduated in the 5 minutes where there was not really a nursing shortage. So I didn't have a lot of choices. So I picked, and I'm very grateful for the experience. I was actually a nurse on the psych unit at the University of Iowa Hospitals and Clinics.
Gotcha. And then on to get a master's and then a Ph.D. in epidemiology. Correct. So tell us, what is an epidemiologist? What is epidemiology?
Well, it literally means the study of epidemics. So, of course, people think a lot about COVID. COVID during the pandemic, I think a lot of people learned more about epidemiology and what that means. But it's broader than just infectious diseases and disease transmission of infectious diseases. It also includes chronic diseases like cancer. And that I just was always really interested in. Again, Chuck Lynch was my first professor. He used to be the director of the Iowa Cancer Registry. And so a lot of his examples that he taught in class were about cancer epidemiology. And just from the get-go, I just knew that's always what I wanted to do.
Mm-hmm. Mm-hmm. So many people might not know that cancer is a reportable disease that is it by federal law or by state law that we're required to report?
I believe it's by state law, but all 50 states have that, some version of that same law.
So we are required to report every cancer case that comes, every invasive cancer, and it's reported in the state of Iowa up through the Iowa Cancer Registry, and then you report on up to a national level where all of the 50 states figures are combined.
Correct. That's right.
So why is it that cancer is a reportable disease?
That's a good question. I believe it kind of dates back to Richard Nixon and the National Cancer Act and kind of the war on cancer. And so they were really had great foresight to build this surveillance system. There's nothing like it. I think in any other kind of disease or condition where in theory we have 100% surveillance of cancer cases. So we're really fortunate that we have that type of surveillance system. And it's to be used for things like research to figure out what treatments are working and what populations are disproportionately affected, and also can be used to evaluate the progress of different programs or policies and initiatives to reduce the cancer burden. So there's a lot of great uses for it, and we really like to promote using it as much as possible, because it's quite an effort to collect
Yes.
hundreds of variables on every single case of cancer.
And it would serve no reason to just collect the data and it sits in a database. So once a year, and I really admire what you have done, especially over the past 5 years, I guess, when I've been aware of it, when the report has become at least more prominently reported on, and this year was no exception. So you had a press conference and you've got this wonderful, I don't know, it's about a 20-page report where you focus on cancers in Iowa, the incidence, the death rate, and then also compare the state of Iowa to the rest of the country and how do we compare. So what would you say were some of the highlights of 2024, your report?
Highlights. Well, the best highlight of it is that our cancer mortality rate or our cancer death rate is still declining, similar to the rest of the country. So we estimated there'll be approximately 6,100 cancer deaths this year among Iowans, and that's down 100 from last year. So that's great to see. That's probably it for the highlights.
That's the positive highlight, but
Yes, yeah.
one of the
The
more Mhm.
Yeah, the less happy and positive key points, I would say, from the report is that we continue, again, to have the second highest cancer incidence rate or rate of new cancers in the country. And we have the fastest growing rate of new cancers in the country.
Wow. So only Kentucky has a higher incidence than the state of Iowa. But
That's
our
correct.
incidence in terms of year to year, the past few years, we're on a trajectory that we're likely to become the state with the highest incidence of cancer.
That's right. Kentucky's incidence rate is coming down. Ours is going up. There's just a handful of other states. Last year, we were the only one with the rate with a rising rate. This year, we're joined by Nebraska, Louisiana, Minnesota, Ohio, and Arkansas are the
Okay.
other ones. So
So, as an epidemiologist, when you see that a cancer incidence is going up, what do you start to think about as you try to discern a reason for that? How does an epidemiologist look at the data with an eye toward trying to explain why does Iowa have an increasing incidence and why are we much higher than people in living in states that surround us?
That's right. And it was just very jarring to learn when we were number two, because it just doesn't seem like we have the socio-demographic profile to be number two, or the risks to be number two. The tricky thing about really kind of figuring out what is driving that is that, as I'm sure everybody in your audience knows, cancer doesn't develop very quickly. Usually it develops over decades sometimes. So we can't exactly look at the risk factors now and know that they are what's playing into our cancer incidence rates now. However, they are the things that we can change now to try to reduce the burden of cancer in Iowa.
Yeah, that's such a
So
good point that you made that, maybe we're number one now because of something that was going on 20 years ago. Um,
That's
But
right.
we tend to go, okay, this is our incidence now. Let's look at some of the risk factors now and see if we can correlate what's going on now with the incidence. But much of what's the cancers that are diagnosed in 2023, many of the things that cause them have been going on for decades.
That's right. That's
Like,
right. And again, and cancer is such a complicated interplay of risk factors. So the analogy that I like to use is, do you remember playing Trivial Pursuit as growing up? And the point was to fill in each of the pieces of the pie with the different questions. Cancer is kind of like the pie, only you don't want to fill it in. When you fill in all the pieces of the pie, you get cancer. So, there's things like genetics. And so those pieces of the pie get filled in for you. There's nothing you can do about those. And then there's maybe some life circumstances that you can't really change that kind of fill in the pieces of the pie. So then you kind of look at, well, what's left that I can change, or that, either as an individual we can change, or as a society we can, have policies that can help with that change. So that's what those are kind of our options for what to focus on now. Now, as I'm more of a cancer surveillance specialist, we're good at counting the cancers and looking at the patterns and the subpopulations in cancers. The expertise we don't have at the registry is the causal studies, like what is causing the cancers. So to help with those studies, we partner with investigators from the University of Iowa or elsewhere, investigators across the country and the world sometimes, who want to look at exposures that they can measure and that they're experts in, and they want to use cancer as an outcome to look at the associations of that. So we're very active in a lot of research studies with other investigators to look at causal associations. But, from the registry level, we can only kind of look at associations or even just patterns, and really, again, focus on the risk factors that we can change now, and in hopes that will reduce our burden eventually of cancer.
Before we look at those risk factors, let's look a little bit at the data. And these are estimates for 2024, so they're obviously based on what we've seen in the past few years. What
Mhm.
are the most common cancers in terms of incidence that we see in Iowa? And are any of the cancers in Iowa that we see commonly, are they seen more frequently than in other surrounding states,
Mhm.
or are we kind of the same order of cancer as just a higher incidence?
Right. I think we have a pretty similar order, but we have some different trends going on recently. So, breast cancer, prostate cancer, lung cancer, and colorectal cancer continue to make up roughly half of all cancer cases in Iowa. Breast cancer, our rates are increasing quite rapidly compared to the rest of the United States. I think we currently have the ninth highest incidence rate in breast cancer, and one of the faster rising rates in the country. When it comes to prostate cancer, it's interesting. We have the fourth highest incidence rate among our Black population in Iowa, and the seventh highest rate among our white population in Iowa. And the rates are rising faster here than in most other states. Melanoma is probably our fifth one. That's kind of comes right behind the others. That's where we have the fifth highest incidence rate here in Iowa, and it's rising faster than in most other states. So breast, prostate, and melanoma together are kind of accounting for a lot of the increase in our rate. But another big player in that is lung cancer, unfortunately. Our incidence of lung cancer is declining, which is great, but it is declining far more slowly in Iowa than it is in the rest of the country. And there's some studies over a longer period that suggest that our incidence rate in females are actually rising since the 90s through now, and in most other states that's declining. So that's a troubling one, since we know many of those cases are preventable through by avoiding tobacco and testing and mitigating for radon.
It's interesting from a clinical perspective that women, there are more women non-smokers that get lung cancer than men non-smokers. So
Mhm.
obviously smoking is still the number one cause, modifiable risk factor for all cancers, in particularly lung cancer. And
Mhm.
most individuals with lung cancer have a smoking history, but not all individuals who get lung cancer have a smoking history. We know radon is one cause for lung cancer, but it's interesting that in women it's going up, because we do see quite a few non-smoking women who get adenocarcinoma, and many of those happen to have um, uh, genomic and molecular uh, targets for which some of our targeted biomarkers are important in women. So I didn't
Yeah.
realize that we actually have the incidence of lung cancer in women is going up in the state of Iowa.
Great. And then I don't want to leave out colorectal cancer, which is another one of our very common cancers. It is declining. We do have the eighth highest rate of colorectal cancer, but our trend in the declining rate is kind of mirrors the rest of the United States. So we're starting at a little higher place, but we're coming down just like the rest of the country. So that's good. There is the issue though of the population under 50, where we do see colorectal cancer rates kind of creeping up in that younger population that doesn't get screening. And I think that there's a lot of research going on to try and figure out why that is. But we do see that population having an increasing colorectal cancer rate in Iowa.
Right. And as you mentioned, we're seeing that across the country, so much so that the recommendations for when to start screening has been reduced to a lower age, because we're seeing so many colorectal cancers at a younger age. So it used to be screening was 50, and then it went down to 45, and I think it may be even dropping to screening starting in some populations at the age of 40 for colorectal cancer.
Right.
You also, in addition to incidents, you track the cancer deaths. And so you gave us kind of the top four in terms of incidents. What about in terms of death, or as we say, mortality? What cancers account for the most cancer deaths in Iowa? I think you said that we're going to have 21,000 new cancers in Iowa, and we'll have about 6,100 deaths this
That's
year.
right. That's right. Unfortunately, lung cancer continues to be the number one cause of cancer deaths. It causes nearly 1 out of every 4 cancer deaths in Iowa. Colorectal cancer is the second most common cause of cancer deaths, and pancreatic cancer is the third most common. So if you take those 3 cancers together, plus breast and prostate cancers, those account for just over half of all cancer deaths in Iowa.
Right, and it's interesting you mentioned pancreas, because pancreas, the incidence in terms of where we are in the order of cancer is very low, but in terms of death, it's the third most common cause of cancer death in Iowa, and
That's right.
obvious,
Go ahead. Sorry.
yeah, related to the fact that unfortunately we don't have great treatment yet for most types of
Mhm.
pancreas cancer.
Yeah, that's right. The survival rate in most other cancers is, continues to improve, and pancreatic cancer it has improved a little bit, but it's been pretty stubborn because, like you said, there just aren't great treatments. And that's certainly one cancer that we've talked about featuring in our Cancer in Iowa report, because it does kind of continue to creep up. But in the report, we like to have a public health message, a kind of what can you do, or what can we do? And that's one that's kind of a head scratcher, because we haven't quite figured out. There's not a screening test for it. There's not great treatment. So there's not a great message to tell people what to do, other than really be aware of your symptoms, and if something doesn't seem right, to make sure you communicate to that to your physician right away. I think it's the target of a lot of research on some of the blood tests, for cancer, that are kind of
Mhm.
new and emerging. But I don't think most of those are kind of ready for prime time, or really great predictors yet at this point. So hopefully that's one that will continue to be a major target of research, so that we can either find it earlier or figure out how to treat it, or both.
Yeah, so just for the everyone listening to know that next week our program is going to be about the new multi-cancer blood test.
Good,
So we're going to learn
good.
all about what the future might be when those have had a bit more chance for the studies to come to fruition. You I think it's interesting that you not only track the incidence of cancer, so new cases, you track cancer deaths, but we have been very successful in lowering the death rate, which means we have a lot more cancer survivors. And you also track how many cancer survivors there are in Iowa. And I think in 2024, it's estimated that we will have 168,000 cancer survivors living. And correct me if I'm wrong, but your definition of a cancer survivor could be someone who has been treated and cured of cancer, or someone who still has cancer and maybe
Mhm.
has cancer as a chronic disease and is being treated but hasn't yet been cured or may never be cured.
That's right. Our definitions aren't perfect, but since we've been in existence since 1973, we basically just, and we track everybody since 1973. We've tracked them from the time of their cancer diagnosis until they pass away. And then each year we try to get the date of last update that we knew somebody was still alive. So we track people for the rest of their lives. And so that kind of lets us go back 50 years and look to see whoever in Iowa do we have record that was diagnosed with cancer and who's still alive today.
So, as you said, tracking the numbers is important, and you can say with quite a bit of certainty what the incidence is, what the death rate is, and how many survivors we have. Those are numbers you count, you report
Mhm.
those, and those are facts. When it gets to what is the cause of cancer in Iowa, that's not something that the database can tell you.
That's right. We start tracking people from the moment of their diagnosis. So we don't have any information prior to that diagnosis. So again, we try to partner with researchers that have big cohort studies or different study designs where they can look at cancer as an outcome. So by linking data sets or using the cancer registry as to register outcomes of people like they did, for example, in the agricultural health study that my predecessor, Chuck Lynch, led. They enrolled, I think, at least 50,000 pesticide applicators in Iowa. I think there was also a cohort in North Carolina. And so the registry was kind of used and is still being used to then, with that cohort, track the people who then get cancer so that research can be done to look back at the risk factors.
So when we look at risk factors, so you and I know this isn't something that we attract or that we just know from data, but from studies that have been done. So we know that some people might have a genetic mutation that could lead to cancer. The most common ones that people have heard of probably are the BRCA mutation or Lynch syndrome in colorectal cancer. We know that cigarette smoking, obesity, lack of physical activity, certain types of diet, alcohol consumption, exposure to certain infectious diseases, radon, ultraviolet radiation. I'm probably leaving out a few. What have I left out, Mary? Can you?
I think you got most of them.
Yeah. So we know that those are risk factors, and we know that besides genetics, with the genes you got, most of those others I mentioned are what we call modifiable risk factors, that we have some ability to control those risk factors. We've, for a long time now, focused on tobacco as a modifiable risk factor. We still know that it is the number one leading cause of cancer as a modifiable risk factor. We know that diet, obesity, physical inactivity, those three together almost as high as tobacco. I think something that the cancer in Iowa focused on this year that a lot of people don't know, but those of us in medicine have known but haven't stressed a lot, is the role that alcohol consumption plays in causing cancer. And the Cancer Registry's report this year takes on alcohol and teaches us a little bit about what types of cancers are associated with alcohol consumption. And then also a little bit of a dive into what are Iowa's drinking patterns and habits. So maybe let's focus on the cancers that alcohol consumption contribute to. So what are the types of cancer that are associated with alcohol consumption?
Start in order of how it goes how it goes down, because a lot of them are what alcohol would touch on its way down. So head and neck cancers like the larynx, pharynx, and oral cavity. Then working your way down to the esophagus, the colon, rectum, and the liver. And then in a different mechanism that I can talk about in a little bit, breast cancer also.
Breast cancer, yeah. So some of those make kind of logical sense, as you said, the mouth, the throat, the voice box, the esophagus, and then everyone kind of, as probably knows, the association of alcohol with liver disease, and in addition to cirrhosis, liver cancer is one that is associated. But breast, yeah, that's a one that many people don't know, the association with alcohol consumption and breast cancer. What's the thought for the pathophysiology, how alcohol consumption contributes to increased risk of breast cancer?
Right. And this is really relevant to the type of breast cancer that's really increasing in Iowa, or kind of driving the increase is hormone receptor positive breast cancer. That's where we see our biggest increases. And that's the most common type of breast cancer that people have. So drinking alcohol actually increases the levels of estrogen in our body, which make us more susceptible or contribute to our risk for cancer. I think studies have shown that compared to non-drinkers, heavy drinkers have nearly 2 times the risk of developing breast cancer.
Wow. And then your study also looked at, because we're always trying to figure out why is Iowa so high. So one logical thing would be, well, what are some of the risk factors like smoking or obesity or physical inactivity or alcohol consumption? Does Iowa currently rank high in terms of these bad habits, if you will?
Right. And, like you said, smoking is a huge risk factor, really arguably the most, directly connected to, multiple types of cancer, including lung cancer, which I talked about as our number one cause of cancer death. But we have featured lung cancer before, both with respect to tobacco and radon. We've also featured obesity related cancers before, and Iowa is, I believe, we're ranked 11th in obesity in the country, so not doing real great in that one either. And we have yet to focus on physical inactivity, which might be an idea for next year that we've talked about. And there we see, only 1 in 5 Iowans may be meeting the recommended guidelines for physical activity. But we did choose to focus this year on alcohol because we saw that, first of all, like you said, most people don't know that connection. And a study showed only 40% of the general public had any idea that alcohol had any connection to cancer. And also we saw that Iowa has one of the highest binge drinking rates in the country. 22% of our population engages in binge drinking. And we saw that we also have the 4th, highest incidence of these cancers that can be alcohol related. And to be clear, the cancers that are called alcohol related or designated that way by the National Cancer Institute does not mean that each of those cancers were caused by alcohol. You can have those types of cancers and never have drank alcohol. It's just known that those are associated and that alcohol has been found to increase your risk of those types of cancers. So since we looked to be pretty off from the rest of the country and have high rates of binge drinking, we thought it was a good use of the report to really feature that association and just build awareness for people. Again, not to say that alcohol is the most important risk factor. I don't think it is, and I don't think it's the only risk factor that's driving our high rates. I think it's taking lots of different risk factors to drive our rates up, and they all sort of are intertwined with each other. But again, we thought it was really important to build awareness of that connection and also build awareness of our high binge drinking rates here in Iowa.
So, Mary, at the cancer registry, you keep track of how many cancers we have. You keep track of how many people that die. You keep track of how many survivors. I would imagine that at the cancer registry, you don't keep track of who's drinking and how many binge drinkers. So, where does the data for alcohol consumption per person per state, and whether how much you're drinking per day, whether you're binge drinking, that's not data that you collect yourself. So where does that data come from?
Correct. So the BRFSS, also known as the Behavioral Risk Factors Surveillance System, which is one of the world's largest telephone surveys that's administered by the CDC. And it's really the survey that assesses a lot of our health risk factors. And so they ask people, I think they do 40,000 interviews a year. And they ask people from a random sampling of the country how much they drink. And so it's probably an underestimate. You can imagine that a lot of people sort of round down on their number of drinks that they have had in the last X days, or how many drinks they have on occasion. So it's probably a bit of an underestimate, but probably most of the other states are doing that too. So it's all kind of relative.
So it does sort of, to use the data and compare states, you're making the assumption that everybody in every part of the country lie in equal measure, and that
correct.
Yeah. And we sort of have joked that maybe one of the problems is Iowans are too truthful, and that we don't drink more, we just admit to it.
That is a possibility.
But that's just a hypothesis. The best thing we have to go on is the assumption that everybody in the country lies in equal measure, and that we can still use the data to compare one state to another. And so when you, and I'm kind of asking you to repeat what you already said. So when you use that data and look at Iowa compared to other states, we are like fourth in the country in terms of binge drinking. And then if you slice and dice the data by women, men, blacks, whites, Hispanics, what are some of the other statistics on how we compare in our drinking pattern to other states?
Yeah, thank you for asking that, because I thought that was like one of the most interesting parts of the report that I think kind of got a little bit lost in all the data, and we did want to stick to our main message, but it's every single way you can slice and dice our population. Iowa has the higher binge drinking rate than the rest of the country. And what's really interesting is some people might think, well, it's the kids in Iowa City and Ames and Cedar Falls, that's probably where the binge drinking is the highest, which is interesting. That's where we're most comparable to other states, is in the 18 to 24-year-old range. When we get to the 25 to 34-year-old range, then we have like more than 35% of our population in Iowa binge drinking, and less, closer to 26% in the rest of the country. Oddly enough, too, as education increases, the gap between Iowa and the rest of the states also increases. Same with income. You get above 100,000 household income and to 200,000, the gap actually gets worse. We are far out binge drinking the rest of the states. Males have a much higher binge drinking rate and a bigger gap between us and the rest of the country. Females, a lower binge drinking rate, and are more similar to the rest of the U.S.
Mary, I kind of wanted to highlight one of the things you said. So when you look at education and income, so with cigarette smoking, the higher the education and the higher the income, the less likely one is to smoke. But I'm hearing you say that with binge drinking, the higher the income and the higher the education, you actually have more binge drinking.
Yeah, it's really interesting. Like I said, above that $100,000 threshold, we have more than 30% of Iowans reporting binge drinking. And that far exceeds those of lower incomes.
And for the purpose,
Oh, sorry, go ahead.
No, for the purpose of the data, how do you define how's binge drinking defined?
It is 5 or more drinks for men on one occasion, and 4 or more drinks for women on one
Okay,
occasion.
gotcha. So, as you pointed out in trying to see what's different about Iowa compared to our neighbors, we know we're a bit more obese. We know we are a bit more inactive. That our diet probably isn't as good. Smoking, we're actually not that bad. We're in the best,
Kind of average. Yeah.
kind of average, but alcohol stands out, and so one of the factors that may be contributing to our incidents.
Right. And it's
Um,
interesting that I think alcohol can work in conjunction with other risk factors too. So it doesn't just work alone, because
mhm.
one of the mechanisms, alcohol itself is a carcinogen and breaks down into a carcinogen in our system. But another way that it contributes to cancer is it inhibits the absorption of really important vitamins and nutrients that help our cells repair damage to the DNA. So other risk factors that are, maybe causing damage, the alcohol is contributing to not letting that get repaired and kind of contributing to cancer in that way. So it doesn't just work alone. It kind of exacerbates other risk factors.
So, when I look at how Iowa might be different from other states, there's two things that I think about, and I want to get into talking about these. These are harder to pin down, or maybe you can share with us what the data does say. So, when you look at the amount of radon that we're sitting on in Iowa, so I think it's a true fact that we have a higher levels of radon than other states, maybe any other state, but certainly we're way up in terms of the amount of radon exposure. And that even though radon has been directly associated with lung cancer, it probably contributes to other cancer. Is there anything that you can say factually, based on research, about the role that radon may be playing in Iowa being number 2 in incidence compared to other states?
I think it stands to reason that, because we have kind of an average, not great, but not the highest smoking rate, but we're not coming down like other states. I think it stands to reason there's some other factor at work there. And I would imagine that radon is one of those other factors at play, that could be in part responsible for the slower decline that we see in Iowa compared to other states. For
Are
sure.
there any studies that you know of that try to associate measured radon levels in the home of Iowans compared to measured radon levels in other states? I mean, that's not a question that's part of the Burfus study, where
Right.
they ask people about their smoking, they ask people about their drinking, they ask people about their diet and their exercise. Is there any sort of nationwide study that tries to compare radon rates and that might show that Iowa is number 1 in the country in terms of radon?
Yeah, that's such a great question. I haven't seen that, but I'm going to go looking for it now. But I haven't seen that because it's such a function of who gets testing, and a lot of people in other states.
Mhm.
Iowa, we've thankfully to many advocacy groups and the Cancer Consortium, and a lot. We've kind of put it at the forefront, and so and it's in our state law. Some forms of testing, and I don't think that exists in a lot of other states. So it's hard to compare, but I would definitely be. Um, I'm definitely interested in figuring that out, but I haven't seen that data.
Sure. We're number 4 in binge drinking. It'd be interesting to know, is there any data that says we're number 1 in radon exposure?
Yeah,
Um,
I just the maps show that I was the only state that the entirety of the state sits in a high risk zone, and but I don't know. I haven't seen the data comparing us to other
okay.
states.
And then the other thing, when you just look at Iowa and look at a map of Iowa and how much of Iowa is farmland percentage-wise, there's probably some way to look that up. Where do we rank among all the other 50 states in terms of the percentage of our land that is farmland? And when you look at farming practices, farming practices today are using lots of different chemicals, fertilizers, pesticides, and herbicides. So we all are wondering, could the ag chemicals that get put into our land that eventually get into our water, uh, could that be contributing to our high cancer incidence? And what would the scientist in you, how would you try to answer that question?
Right. Well, we are wondering that too. And as I said earlier, unfortunately, we don't do that type of research at the registry, so we have to partner with other organizations and investigators. So I mentioned one example is the agricultural health study. The active, like adding to that cohort, is done now, but they have a very large cohort of the original 50,000 pesticide applicators, their spouses, their children. I think they might even have some grandchildren now, and now they've poked and prodded these people. They got cheek cells. They asked them lots of questions and lots of surveys, all kinds of different measurements they've taken on these people, and asked about lots of different exposures to lots of different chemicals and about their drinking water. I think they might have even tested some of their wells and water and all that type of thing. And now they just are sort of waiting for the outcomes to happen because, again, cancer happens over decades. So we partner with them in providing them the outcome data that it will take for them to really be able to drill in and figure out which exposures cause or at least are associated with which cancers. So that's one example. We're also in the process of participating with the NCI in a study where they're going to link our data to a lot of different environmental data sets to do a lot of research on. I think that one's a little bit more geared towards air pollution than it is to like agricultural related risk factors. We also work with investigators at CHEEC, the Center for the Health Effects of Environmental Contamination. And they're really interested in the impact of nitrates in the water and PFAS in the water. And so we're working, some of the investigators associated with the registry are working on a grant with them to really look at the association between some of those exposures and cancer. And we're starting to try and think of ways that we can do more proactive cancer cluster investigations in Iowa by, targeting, we know Comanche, for example, is a city where had, terrible contamination of their drinking water with PFAS to the extent that I think the company responsible had to replace their municipal drinking water system. So that's a place where we want to just start keeping our eye on, what are the types of cancers they're getting and at what rates and in what proportions are they getting there, and watch that over the years. But again, it could take a while for cancers to develop if there is in fact an association.
Is there are you aware whether there is a place where data is collected on drinking water, and not just nitrates, but obviously you've got so many different ag chemicals where one can say this state or this city has a level of this amount of, whether it's Roundup or a fertilizer or an herbicide, and so that that can then be correlated to incidence of cancer. It would seem that the study you reported or that is being done is about individuals that were applying pesticides or that were directly ag workers, but
Right.
I would see that it's possible that yes, they're at risk, but whoever drinks it as it comes downstream and whatever gets through the water purification,
Mhm.
it may be at risk, because some of these carcinogens may be carcinogenic at really low rates. It's not like you got your whole body sprayed by it when you were
Mhm.
doing crop dusting or whatever, but that small traces could increase the risk.
Yeah, I think that's kind of one of the things that Cheek does track in different ways, and so I think that's going to be part of the research grant that we look at in combining our cancer data with the data they have on water supplies. I think one of the big sort of unknowns is well water. We still have a lot of people on well water, and that's where it's less known what is in that water. Not everybody has their water tested. Just basic kind of water softeners or municipal water systems, is my understanding that something like radium, which is related to radon, kind of sort of comes from the same limestone or whatever rock formation, that we sit on in Iowa. And municipal water systems would, even a simple water softener can scrub out radium. But if you're drinking from a well in a part of the state where it's down into that rock, there's chances that there's things like radium in your water, which, like radon, can contribute to cancer risks. So I know that's another area of research and investigation that's going on.
Great. Any highlights that you reported on that we haven't covered yet today in terms of the Cancer in Iowa 2024 report?
I think so. I think we've kind of gotten to most of it. I guess, well, one thing I will say about, and kind of to the question that you just asked, again, I think we need to do our research on our environment and understand that piece of the pie. But the geographic distribution of the different cancers in Iowa suggests that there can't be just one thing. It can't be just the water, or it can't be just the alcohol, or it can't be just the any other kind of point source exposure. And that's because for each of the different types of cancer we've been talking about, we see very different geographic patterns, which means that it has to be sort of this complex interplay of so many different risk factors. So, for example, lung cancer, when we look at lung cancer rates, we see pretty high rates in the southern few tiers of counties in Iowa. When we look at melanoma, we see the opposite. It's the northern counties where we see higher rates of melanoma. When we look at prostate cancer, we see the western part of the state has the highest rates of prostate cancer. When we look at the breast cancer, we see it's the women in the cities, the most urban areas in Iowa, that have the highest rates. So these very different geographic patterns suggest that it's got to be a complex combination of different risk factors. And so that's why we're always interested in doing the research for the ones we know less about. But also, really think it's important to stress the risk factors that we do know about, that you talked about how they are modifiable. And we also, as you mentioned at the beginning, we pass our data on, de-identified, of course, to the National Cancer Institute, where they have it in a database that you can apply to get that data and use that data. So that's available for researchers. And the more the merrier to help figure out, why does Iowa have increasing rates and why are we so high? And we're, again, happy to work with researchers. And we have a lot of good tools. If you just Google the Iowa Cancer Registry, there's mapping tools where you can look at your local area. You can look at patterns by county or even by zip code. And so we just encourage everybody to, put our heads together and try and figure out what's going on.
You mentioned something that I wanted to have you expound upon and invite the audience to submit information, that this cluster analysis. So occasionally we'll hear that within this one school, 4 teachers have been diagnosed with cancer, or within this one county that 3 young farmers were diagnosed with glioblastoma. When someone is aware of something like that, that seems like, gosh, this doesn't seem like it could be a coincidence, you actually, as part of your role as the state epidemiologist, investigate possible clusters, correct?
That's right. We use our data to kind of hone in on the area of concern. And then we work with the person reporting the potential cluster or concern to find a comparable area to that, which is comparable in every way it can be, except for what that exposure might be or what they suspect might be causing that. And then we look at the different distributions of cancers and the rates of cancers. We've done, I think well over 160 of these, and only 2 have really turned up where there was a statistical concern where we notified the CDC.
Okay, so if someone is aware of a possible cluster, what's the method by which they reach out to you to inform you of their concern?
Yeah, if you Google the Iowa Cancer Registry and see the contact information there, you're welcome to email us or call. If you even call your local county health department or anything, they know to get in contact with us. So there's lots of different ways in. You can Google me. You just Google Mary Cancer in Iowa. I think I come right up. So welcome to email those concerns directly to me.
Okay, great. Let's open it up to questions. So those of you that are watching us live streaming, you can put your questions in the comment section, and we have a live studio audience in the room with me today. So we'll turn to them first for questions. Poon.
My question is, so we have this high radon in the state of Iowa. I think like over 50% of our homes have had radon. So why isn't there a requirement to have new construction be tested for radon in Iowa?
Yeah, that's a good question. Dick probably knows the answer better than I do. I'm going to turn that one to you.
Yeah, so obviously, if it was up to the Iowa Cancer Registry to have administrative action to put laws into effect, you would do so. But it does require involving public policy. And anytime you want to change the way in which something is done, you're going to be affecting some people in the pocketbook. So to say everybody has to undergo an inspection, there are realtors and people involved in buying and selling of houses who would be opposed to it because of the added expense. I think that your question is very good. If our primary concern is to reduce the risk of cancer, then we would be doing that. We would be increasing the price, the tax on a packet of cigarettes. We would be increasing the tax on a bottle of liquor. We would be doing everything to reduce those modifiable risk factors. But every one of those public initiatives does affect individuals who then would oppose it, and it ends up being a debate within our legislatures across the country and in Washington, D.C., and you come out with a give and take, and almost everything ends up being a compromise. We were talking about alcohol. There was a time in the United States of America where alcohol was made illegal. And even though from a health perspective, you could probably support that, but not everything is wholly good or wholly bad. And we decided that there are benefits socially and quality of life to being able to consume alcohol. So even though you could make a case of public policy that if you wanted to reduce those cancers, you would outlaw alcohol, we tried that experiment and it didn't work. So my answer is just that there's risks and benefits and positives and negatives of many things. And when you look at everything from every direction, we come out with compromises. Other questions?
Yeah, I have a question. I was out for a little bit, but did you talk about the papilloma virus in
HPV? We didn't talk a lot about that. We mentioned it at the beginning. So, Mary, what does the Cancer Registry have to say about HPV related cancers? I know that was a focus last year or the year before.
Yeah, well, so head and neck cancer, which is a big HPV associated cancer, we are number 2 in the whole country, and we have the fastest rising rate of head and neck cancer. That's a really interesting one where if you remember when I said that alcohol can kind of work with other risk factors, that's one where it absolutely interacts. And so the otolaryngologist or head and neck surgeon that we had at our press conference kind of did a good job explaining. She sees a lot of patients with, or a lot of the patients she sees with HPV associated head and neck cancer also drink and smoke. That those sort of risk factors kind of work together. And, unfortunately, the pandemic did not instill more confidence in vaccines. So we are struggling to really even get any sort of traction on increasing the HPV vaccination rate in Iowa, which is a real shame, since it could actually be prevented in this next generation here.
Right. So there are 6 cancers that are associated with HPV, the human papilloma virus, and we have a vaccine for the human papilloma virus, but it is our vaccination rate on HPV, I think, is somewhere down in 40% range. So even when we do the science and the studies and come up with a solution to 6 cancers, it's available to every child, and we're still only vaccinating 40%. So I'm glad you brought that up, because that is a modifiable risk factor, and we could actually eliminate some cancers completely. For example, cervix cancer in women, 100% of cervix cancers are caused by HPV. In oral pharynx cancer in the throat is maybe 70% of those cancers. But in my time as a cancer doctor, 35 years ago, if we saw someone with a cancer in the region of the tonsil, it was almost always alcohol and tobacco related. Now, I would say most of the HPV tonsil-like cancers we find, they're not smokers, they're HPV. Many of them probably do have alcohol as a risk factor, but it's really changed a lot over the last several decades, where it used to be someone with throat cancer, heavy smoker, heavy drinker, not good oral hygiene, and now many highly educated white-collar individuals with great hygiene and no smoking are having HPV-related oral pharynx cancer. That's of the tonsil region. And as Dr. Charlton pointed out, we're number 2 in the country in terms of incidence of that type of cancer.
That's right. And it's like you said, there's other states who have focused on eradicating cervical cancer altogether. So it's achievable, but not with our vaccination rates where they are. Yes. And hopefully, if you see on page 14 of the Cancer in Iowa report, we did actually feature Emily Hoffman, who's a cervical cancer survivor, who has an amazing story. But, and that's one, I know we're running out of time. That's one last point. So a lot of people say, well, if our cancer mortality rates are going down, what's the big deal? If our cancer rates are going up, that probably means we're just screening better and we're catching them early. And so it's a positive, right? And that may be true to some extent. That is the good news, is that our cancer rate is declining. But our cancer rates are not, our screening rates aren't going up proportionally to our cancer rate. So it's not just because we're screening more. And if you read stories from people like Emily, who got cervical cancer early in her life and had terrible side effects from the treatment that she deals with every day of her life, cancer sucks, and it's terrible to go through it. It's terrible to go through the treatment. And so we really ought to be trying to figure out ways to prevent it altogether than just focus on the good news that people aren't dying from it as much.
That's a good point to end. And I know we have other questions, but we're going to have to bring it to a halt right now. But we will have you back again next year. Dr. Mary Charlton, she is the state epidemiologist and runs the Iowa Cancer Registry, and is associate professor of epidemiology at the University of Iowa. And I hope I got all of those titles right, and she's a very
Close
good
enough.
person. So thank you, Mary, for being with us. If those of you watching us know someone that would benefit by watching this program, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. I hope you'll join us again next week for our cancer education series. Thank you.